when I can. It's 10 o'clock, so I guess I should begin.
Yep.
All right. Thanks very much for the invitation to give this talk. I have no disclosures to make, but I'm going to request you guys to see the link at the bottom. Just open a screen on the side. There'll be a few questions there. I'm going to share just a very quick interactive something before we start. Okay. Can you see that pink screen?
See, what country are you attending from?
Correct. So if you type the link at the top or that address at the top into a browser window, just type in which country you're listening in from. So there's lots of Canada attendees. That's only one person logged in. Excellent. There's a few more logging in. So there's 3 logged in. I think I saw quite a few online.
Yeah, there's 25 total. That includes us, though.
Okay, excellent. Yep, there's a few more getting in. There's a few questions, so take a minute to just type the address that's at the top of the screen. Six are now logged in. There, 5 are from Canada. Okay. This is the platform we'll use for interaction. So type that address that you see at the top into a browser window, and you can also do it from a cell phone. Okay, excellent. So there's some South Africans, Brazilians. Excellent. It's nice. Okay, there's a few more coming on now. Excellent. South Africa and Brazil. It's wonderful. Okay, if you just clicking in to look at this, just type that address ahaslides.com/52406 into a browser window. You can do that on your cell phone, or you can do it on your computer in another window. And don't worry, you're not going to miss the presentation while you do this. Yep, 10 logged in Hong Kong, wonderful. Okay. So almost half the group. Okay, Brazil, Canada, South Africa, Hong Kong. And stay logged on, don't log off once you've answered this, because there's a few more questions coming up. Or don't close the browser window. And you can open it on the side and share it with your Zoom window, but you won't be missing anything. Okay. All right, half the group is on. So I'll move on to South Africa, Hong Kong, Canada, Brazil. In the interest of time, I'll move to the next question. What's the weather like where you are right now? No, unfortunately, no one can. I'm not going to accept someone to take control of my screen. So it's a dark night. It's rainy and dreary in a lot of places, and a bit chilly elsewhere. Okay. Maybe a bit of a dark night, but there's quite a few who are enjoying summer. Okay, excellent. And there's a few more that have logged on now. Okay. So lots of rain and winter in the majority of places. Okay, excellent. I'll take a sunny summer anytime, but I guess not today. All right. The next question is, what's your profession? So RN and advanced practice nurse, or an MD, or cardiac tech, other. Okay, excellent. So we have good representation. I should have added a slide to find out who the other was, because we do have a few. Excellent. So mostly RNs, 2 MDs, 2 advanced practice nurses. Okay, I'll keep that in mind next time. What do you hope to learn today? And this is just free text. I'll give you my objectives, but let's see what you hope to pick up from this talk today, or what you'd like to cover. We'll see how much of it we get through. And it's just free text typing. Valve replacements, okay. I can promise that we'll talk about that. Okay, post-op valve repair care, valvular disease. Okay, all about valves. All right. Okay. So majority want to learn about valve replacements, mitral regurgitation, mitral valve prolapse, mitral stenosis. Okay. Excellent. Complications. Complications. Okay. Not much on the complications. Complications of valves. Okay. Pre-op, post-op management. Okay. Cecilia, I'll need another session definitely, but we'll talk about that offline. Valvular disease. All right. Now, I'll close that session. How many of you are able to undertake valve repairs and replacements at your institutions? Okay, so majority can, but there's a few who do not undertake valve replacements, repairs. Okay. All right, and so the majority have that. And cardiac catheterization, how many of your institutions have access to a cath lab? Okay, so almost everyone does. All right, there's 13 online. Okay, perfect. I think that's it. All right, excellent. So I can promise that we'll cover some of those objectives. Can you just confirm that you can see my presentation?
Survey.
Not yet. Okay, let's do this. It should be up now.
Yes, yeah.
Okay, excellent. All right, so what do I have planned? So we'll talk about some common etiologies of valvular disease in children, indications. We'll talk about indications for intervention in valvular disease. We'll describe outcomes for patients who have undergone interventions, and we'll spend a little time at the end discussing complications associated with valve replacements, or with valve replacements. You'll need to relate a lot of what we discussed to the initial presentation I gave on pediatric heart failure. I'll not go over that detail again. And I know that one of the expectations was discussion of post-op care. There's not too much about that, but if we have time at the end, I'm happy to talk about that as well. So just a quick review of valvular anatomy. This is something that will be familiar to most of you, the heart that we started drawing from high school, but that is more of the cardiologist's view of the heart. You've got the aortic valve wedged in there, and the pulmonary valve that's a bit more anterior, and then the tricuspid valve on the right side, and the mitral valve, or the double leaflet valve on the left side. So this is typically how the surgeons look at it, and that's how cardiologists eventually learn to look at it. And that's how you will eventually learn to look at valves. In terms of abnormalities, so the terms that we'll use that you'll hear us referring to along the way are stenosis, atresia, and regurgitation. So regurgitation referring to the leaky valve, stenosis being too narrow, and atresia, complete obstruction. Although we'll spend less time on the atresia portion, but talk a bit more about stenosis and leaky valves. And then in terms of etiologies, they can be congenital and they can be acquired. So that's just something to keep in mind. And then in terms of interventions, you have either percutaneous valvuloplasty. So this is what you would do in the cath lab or surgical repair. And in both of these, you preserve the native valve, and then you have valve replacement, which can also be surgical or percutaneous, in which a replacement is done. There's a lot of guidelines out there that I recommend that you spend some time taking a look at. From there's North American guidelines, from the American Heart Association, there's European guidelines, and then there's guidelines, so indications for cardiac catheterization in pediatrics. There aren't very specific valve guidelines for pediatrics. We extrapolate a lot of what we do from adult guidelines because there's shared practices in there. And we just don't have a lot of literature on pediatric, on some of the pediatric problems, but that's an evolving field. Now, the guideline that you choose to use depends on where your center is located. So if you're outside North America, the European guidelines might be, what you use, or you might have local guidelines. But then, so care is guided based a lot on institutional practice and with a bit of advice from the guidelines. So let's start off with aortic valve disease. And those are the terms that you can see again there, stenosis and regurgitation we'll talk about. But valvar aortic stenosis is one of the most common congenital outflow tract obstructions, comprise about 80% of what we'll see. And then there's other different categories of subvalvar and supravalvar stenosis, meaning it's above the valve. So subvalvar would be somewhere down there, and supravalvar would be up here. But this is valvar stenosis that you can see on there. And the most common cause of this is the bicuspid aortic valve. But the important thing to note is when you have a child with this, there's usually associated lesions, so including coarctation, PDAs, and VSDs. And one of the more significant ones that you need to know about is critical aortic stenosis, which we talked about as a cause of acute heart failure in the neonate. And this is defined by a situation where you've got ductal-dependent systemic blood flow, and there's associated anomalies in up to 25% of these children. So either they'll have coarctation or a duct or a VSD. It's not unusual for them to have a small left-sided structures, and they present in cardiogenic shock after closure of the ducts. It's an emergency. We discussed this when we talked about acute heart failure, and your approach would be to commence prostaglandin, reopen the duct to provide systemic blood flow, and then take these children for urgent surgical intervention. And there is, from the guidelines, aortic valvuloplasty is indicated regardless of the valve gradient in the newborn who's got critical valvar stenosis, who is duct dependent, or in children with valvar stenosis who have depressed left ventricular function. So in both of those cases, this problem needs to be addressed, and these interventions are typically done in the cardiac catheterization laboratory. So I'll show you a few of these things. So the long-term outcomes typically tend to be good. Now there's two approaches. You can, the more contemporary approach is to take these children to the cardiac catheterization laboratory, and there's good evidence for that. From what you can see on here, the BAV, the line at the top, are those who underwent balloon aortic valve dilation, and these ones underwent surgical valve dilation. So you can see that the survival is not really different between the two groups. When you think of how many of them eventually needed re-intervention, so by about the 5-year mark out here, almost half of the group had needed surgical intervention. So you can see that even though taking them to the cath lab is the appropriate thing to do and it buys time, by the 5-year mark, there's a lot of them who will need to go back to either the cath lab for reballooning or undergo a surgical procedure. And one of the other interesting findings in terms of freedom from reintervention stratified by the type of whether they had initially undergone a balloon or surgical intervention, it wasn't that different. But what was noted was that the patients who had undergone surgical intervention at the beginning were more likely to have stenosis, while those who had undergone balloon dilation were more likely to have regurgitation. So none of those is a good thing, but what it does is that it buys time for the child to grow. And in terms of longer term outcomes, this was another much bigger study. You can see that even after they have undergone the initial intervention, by about the 20-year mark, the curves intersect. So at some point they definitely have to go back. They have to go back to the lab. So during the follow-up of these about 220 patients, almost 44% had gone and undergone a re-intervention on the aortic valve. But survival is after aortic re-intervention was pretty good. So 89% at 1 year, but then they all do end up needing a re-intervention at some point. So although it is effective for initial relief of the congenital aortic stenosis, there are definitely long-term hazards that you must bear in mind. The big take-home message from this is that a neonate born with critical aortic stenosis who goes to the cath lab and gets an initial intervention is not out of trouble and must be followed up in the long term. Now, the bicuspid aortic valve we talked about, it's the most common congenital cardiac defect. And the reason it's important or the reason we discuss it is that these patients will often develop aortic stenosis or aortic incompetence later in life. There's an increased risk of infective endocarditis and thrombus formation. And a thrombus in your aorta is a risk for a stroke, but they also do develop ascending aortic aneurysms, and they can get aortic dissection and hemorrhage to death. It tends to be, depending on the severity, it's a bigger problem later in life, but it's just something to keep in mind, and it tends to run in families. So if you identify a child with a bicuspid aortic valve, you need to look in the rest of the family. And how do they present? Again, this is depending on the severity. They'll present with heart failure symptoms, critical AS we've just talked about, and interventions either in the cath lab or in the surgical lab. Now, these are the European guidelines. It's a little fine print which you can take time to look at. I'll circulate these slides to you, so don't struggle too much with reading. But in terms of what's on the AHA guidelines, if these patients, if the patients are symptomatic, then already it is an indication for them to undergo intervention. And symptomatic, there's a gradient, a cutoff that's usually used, a gradient above 40. Or if they have decreased left ventricular function, that's another indication to make sure they get an intervention. But if they are asymptomatic and they're having another surgery, then you might as well deal with that difficult valve. Now, aortic regurgitation, I'll let this play so that you appreciate what the cardiologists typically see. As an isolated lesion is rare, but like I'd mentioned before, we'll see this after children have undergone intervention in the cath lab for a stenotic aortic valve initially, but it's also seen especially with infective endocarditis, rheumatic heart disease in patients with VSDs. So it's while it might be rare as an isolated lesion, it's definitely associated with many other disease. And it is initially asymptomatic, but as it progressively worsens, then the patients will develop impaired LV dilation, LV dysfunction, and they even get impaired coronary perfusion and eventually present with heart failure symptoms. Echocardiography is a really good way to diagnose this. Not much other imaging is needed. Okay, so I think I doubled up that slide. Again, there's indications for surgery. So I've put the European guidelines there for those who may not be in North America. And I'll circulate these, but if a patient is symptomatic, then they need to get an intervention. if they're asymptomatic, but they have reduced left ventricular ejection fraction, then they also need to get an intervention. And it should be a multidisciplinary team discussion between the cardiologists and the surgeons and the interventionists regarding how to undertake this. And the other reason I included this is that we will typically see there's a special group of patients who get aortic root disease, so the Marfan or connective tissue type patients, they can get aortic root dilation and regurgitation. It's important to keep those in mind. The criteria tend to be a bit different for them. But with the take-home message from this is that if a patient is symptomatic or has decreased left ventricular function or is undergoing another surgery, they need to get an intervention done. So what are the types of interventions that are available for these patients? They can either undergo repair, which is the preferred. There's no need for anticoagulation because it's native valve tissue. Although initially they might be on a bit of aspirin for the first several months, but then there's replacement, which is the other option when the valve is unrepairable. And we'll talk about the options that are available for that. There's anticoagulation needs that need to be borne in mind, and then replacement valves. Replacement valves, they can get complications. Some of them have finite lifespans. So again, that is something to think about. Now, a few of the options that are available are the allograft or the homograft, which can be sourced from human cadavers. They're usually cryopreserved, and because it's tissue, it's a tissue valve, they don't need anticoagulation. The big problem with this is that they are not very durable, and a lot of these patients need to undergo earlier reintervention, and I'll show you some data to support that assertion. The autograft is what is more commonly known as the Ross procedure, where the pulmonary root and the pulmonary valve, which would have been here, are transplanted over onto the aortic side, and the diseased aortic valve and proximal ascending aorta are taken out. The coronary buttons are replaced into this neo-aortic root, and then a conduit or a homograft is used in the pulmonary valve position. So this is the so-called Ross procedure. The advantage of this is that because this is the child's own tissue, it will grow with the child, but this particular part will not grow with the child. So a lot of these patients do need reintervention on the right side, but the results are promising for interventions on the left side, and there's literature to support the fact that there's better hemodynamics than with the homograft on the aortic side. And this was a study of about 100 patients, and in this you can see that in terms of survival, there was not much difference whether it was an autograft or an allograft. Looking out several months postoperatively, there were still excellent clinical results in both groups. The only difference was that the patients who underwent an allograft needed reintervention earlier because of the finite lifespan of that compared to those who needed an autograft. But those who get the Ross procedure or the autograft usually need interventions much later in life. Now, in terms of aortic valve replacements, they're either bioprosthetic, so they can be sourced from bovine sources or sapiens. The bovine and the sapien are the different types. They're glutaraldehyde treated. And then these typically small valves, they need to be upsized as the child grows because they do not grow with the patient. And the other patient are the other side of it are the mechanical valves, which are great for the systemic side. They do not, these are metallic valves or synthetic tissues, so they're a bit more durable. And then, but the risk with this is that they need lifelong anticoagulation. There's always a risk of conduction tissue injury. So in the postoperative phase, when a patient has undergone a mechanical valve replacement, you need to keep a very close eye on what's happening with their rhythm and their conduction. And that's what they'll typically look like. In terms of then other options for the aortic side is something called the Bentall procedure. You'll probably hear this, and I'm not going to dwell too much on this, but just thought I'd throw it in there so you have an idea of what it is. And in this case, the patient undergoes, so you have a mechanical aortic valve replacement, but in addition to that, you have replacement of the ascending aorta. And this is more commonly done in patients who've got a very dilated ascending aorta, so they with a diseased valve, which is, so in patients with a bicuspid aortic valve, for example, they eventually develop regurgitation or severe stenosis, and then they get ascending aortic root dilation. And this is the place where there's a risk of dissection or rupture and hemorrhaging to death. So that is all replaced with a conduit made of synthetic or bioprosthetic material. Now, in terms of outcomes, how do these patients do once we've done all this stuff for them? Survival is pretty good. Survival at about the 10-year mark was about 80% in this study. And in terms of freedom from reoperation, again, when they get aortic valve replacements, they tend to be so by about that 10-year mark, you have about almost close to 80% of them who have not needed re-intervention. So it's quite durable. But in terms of patients who need re-interventions, when they get a valve replacement when they're younger, and those are the patients who get a much smaller sized valve, those will need to be intervened on much earlier. So by the 10th year, you can see that almost 80% of them will have needed an intervention. And that is one of the reasons why aortic valve replacement is delayed. Attempts are made to delay it as long as possible, because if they get a much bigger valve, then they tend to get more mileage out of it. There's well, I guess there's a bit more detail that we can talk about if there's questions at the end, but I'm going to be mindful of how much time there is. In terms of mitral valve disease, it can be congenital or acquired. And the most common lesions, again, the mitral valve is either stenotic or it's too leaky. And when it is too narrow, you have to think about the problem either being the valve or being the valve apparatus below the valve. Sometimes there's problems above the valve itself. But for our case, we'll just be talking about valve abnormalities. And the problem that this causes is you've got obstruction from the LA to the LV. So you have pressures building up, elevated left atrial pressures or left atrial hypertension, then they get pulmonary venous congestion, develop congestive heart failure, and then will show up at your practice. And this is what we discussed when we talked about heart failure. Mitral regurgitation, on the other hand, is most often acquired, especially in the older children. Rheumatic heart disease is a significant cause of this, myocarditis, caudal rupture, then coronary artery disease. We'll talk about Kawasaki later today. And then sometimes there's children who are just born with a very abnormal looking valve. And I put this picture in to show you, these are supposed to be very nice and thin leaflets, but you can see these very rolled up edges. It's almost like a pastry. These are supposed to be nice and thin strands. So all these children end up with inadequate systemic output, get left atrial hypertension, and develop congestive heart failure. And this is what we typically see on the echocardiograms. If they develop this when they're much younger, then they fail to grow because there's increased caloric requirements to deal with this regurgitation. We talked about that in the heart failure talk. They get recurrent respiratory tract infections. And then the older children will get exertional intolerance, they'll get systemic venous congestion, they'll get respiratory symptoms. So it's good to identify them early. And at what point do you intervene? So if they're symptomatic and poor LV function, then yes, you must do something. And then if their ventricle is dilating, just growing bigger, it will eventually fall off the wagon. So you have to do something. But also if their quality of life, there's very symptomatic class 3, class 4 New York Heart Association, then symptoms, you're definitely forced to intervene. And most of the interventions they're all surgical. There's not a lot in pediatrics where we can do transcatheter interventions. Repairs are preferable, and those are the different types of repairs that you can see. You'll hear a bit about annuloplasty and papillary muscle splitting, or some, membrane resection. I'll share this slide so you don't have to stress too much to write notes. But then when that mitral valve repairs, what the data shows is that these repairs are they're not that durable. And by the 10-year mark, you can see that by your 10th year, almost half of the group has needed to undergo reintervention. And then you can see that over the years, they eventually develop valve failure. So for the mitral valve or for systemic valves, as we discussed with the aortic valves, repair is not really that durable. So then replacement becomes the other option. And at our institution, our most commonly used valve is that the St. Jude. This is a nice ancient one that used to be used several years ago. But of course, when this mechanical valve goes in early, then there's anticoagulation requirements, and these are lifelong requirements. There's the risk of left ventricular outflow tract obstruction. If a big valve goes into a very small baby, there's a risk of injury to the conduction system. And if the outflow tract is obstructed, then there's a risk of death, and we'll talk about some complications at the end. And mitral valve replacement does give you, slightly better longer term outcomes. In terms of survival, by the 10-year point, there was about about 74% of them were still alive at that point. But as you can appreciate, there's a group that falls off, that dies, and it's quite steep early on, but then it levels off through the years. And then there's a small group of patients that need to have re-interventions done. But overall, it's much better than just the mitral valve replacements. And then in terms of mechanical versus bioprosthetic, which one is better in the longer term? This is adult literature, but longer term survival was not really that different between the two groups. So if you have a good bioprosthetic, then yeah, it's a great option. The mechanical valves, there's a need for lifelong anticoagulation. So the bleeding risk, especially as children grow older, if they're playing rugby or football, and then as they age, the risk of hemorrhagic complications tends to increase. So that's something to bear in mind. So still have a bit of time. Let's talk a bit about pulmonary valve disease. So here I'll spend time just talking about pulmonary stenosis, which is the most common lesion that you'll see in neonates. And just like we talked about critical aortic stenosis, there's critical pulmonary stenosis, which is, as you guessed, duct-dependent duct-dependent pulmonary blood flow. And these are neonates who will be quite cyanosed at birth. Re-intervention is in the cath lab with the aim of providing antegrade flow to the lungs. But the thing about this particular group of patients is they usually have a very thickened right ventricle. So in the immediate postoperative phase, they might still be desaturated, and a few of them need to stay on prostaglandin until that thickened right ventricle has remodeled enough to be able to pump sufficient flow across the pulmonary valve. So these are patients who might sit in the hospital on a bit of prostaglandin for a week or two while this right ventricle remodels. But if the obstruction is below the level of the valve, that cannot be addressed in the cardiac catheterization lab, and they need to go in for surgery instead. The guidelines, I'll just focus on that one, but you'll have the rest of this content that you can review. So for patients who have critical pulmonary stenosis, they definitely must go to the lab, or those who have moderate to severe stenosis, so gradients of more than 40. For those interested in a bit more reading, then yes, those need to go to the lab. And the reassuring thing is that unlike the aortic valve patients, these neonates tend to have this intervention. For some of them might be the only intervention they need. And in this data where they looked at children who are below 3 kilograms, there were, by the 10th year, about 75% of them had still not required a re-intervention. There's a few of them who die at the initial point and those who need surgery, but again, that is just in the very early stages. The rest of the life tends to be better. So if you had to choose between aortic and pulmonary stenosis, you're probably better off with critical pulmonary stenosis. The outcomes tend to be better postoperatively, but as we discussed, they may need to sit in the hospital for a few weeks while that right ventricle remodels, and in the post procedure period, their saturations must be closely monitored. Pulmonary valve regurgitation, there's a risk of developing this in the long term after intervention on the pulmonary valve, but this is something that's also commonly seen with other conditions, especially tetralogy of Fallot, and in the long term, they get they develop right ventricular failure, right ventricular dilation, and the indications for replacement include exercise intolerance, heart failure, syncope, ventricular tachycardia because of the increased risk of sudden death. And then there's other criteria they use, like MRI volumes for those of you that work in centers that have access to cardiac MRI, and valve. Under these conditions, then the valve replacement is undertaken, and what is preferred in the current era is replacement in the catheterization lab. And these are the available options. There's the melody valve, which is what a lot of institutions will use, but there's the Sapien and then there's the Harmony. So there's different options that are available. Costly, but the good, the advantage of these bioprosthetics is that there's not much in terms of anticoagulation needs. They tend to be relatively durable because there's lower pressures on the pulmonary side to deal with. And that's what it would look like in the cardiac catheterization lab. So the valve is implanted, it's mounted in a stent, which is implanted in the RVOT. And not all patients are candidates for this. If the anatomy of the RVOT is not favorable, then they would need to go and have this done surgically. In terms of, when you look at long-term impact, freedom from reoperation is, it's pretty decent. Survival is pretty good. And freedom from VT or death is the big thing, because what we say, the indications we said, we're trying to prevent them from, dying suddenly. But in this particular study, the cohort experienced either VT or death, at least once every 20 patient years. So there wasn't, it didn't seem like pulmonary valve replacement reduced the incidence of ventricular tachycardia or kept them from dying suddenly. And if you have the opportunity to attend a conference that has an RV symposium, I would strongly recommend it, because this is another of those where the discussions tend to be, there's two sides to the coin, and there is very little in the middle ground. In terms of the postoperative period, when these patients come back from the cath lab, they take a bit of aspirin and infective endocarditis prophylaxis for the first 3 to 6 months, depending on your center. But after that, quality of life tends to improve. Exercise tolerance is much better. You watch out for cardiac post-cath lab complications. So usually access at the site. There's risks that come with cardiac, with interventions in the cath lab, including vascular injury, cardiac perforation, injury to the valves, and injury to the conduction system. But if none of that happens, these patients typically recover quickly and leave the hospital very quickly. So on that front, they tend to do well in the post-op phase, but they must still be followed up. Changing gears and moving on to tricuspid valve disease, I'll talk about one or two common problems with the tricuspid valve. So Ebstein's anomaly is the most common that you might have to deal with, where there is apical displacement of the, so if that was supposed to have been your tricuspid valve annulus, but then they end up being plastered to the wall, and you end up with a very small functional RV because the valve leaflets are down there. It tends to be a very incompetent valve. So over time, they develop this progressive right atrial dilation, and it can start in utero, and with an inability to get forward flow into the pulmonary arteries. So they often have duct-dependent pulmonary blood flow. And at birth, they can present with cyanosis, with heart failure, and with arrhythmias. And this is the typical chest X-ray, what is called the wall-to-wall heart. So if parents bring in a blue neonate whose X-ray looks like this, you'd be, within 90% of saying, yeah, this is going to be Ebstein's anomaly. Now, this is a severe spectrum, and there's patients who have been diagnosed later in life. There are patients who are diagnosed as teenagers when they first present with arrhythmia. So the spectrum is very variable, but this is the more severe form that we are talking about, where they need a valvular intervention. And the preferred management for this is what they call the cone procedure, where the leaflets are modified and shaped into a cone. But of course, in the post-operative issues, they're working with, you have to remember your conduction system is usually quite close to your tricuspid valve, and your AV node is somewhere around there. So arrhythmias and AV blocks tends to be a big issue in the post-operative phase. Longer term, their right ventricle might struggle, and then if this opening is too small, or they do get a bit of stenosis, then they end up with significant effusions, prolonged drainage from their chest tubes. They might have an inability to wean off respiratory support. So those are just things to keep in mind as complications that they can develop. But also in addition, a lot of them, if I go back to that X-ray, when you look at this heart, there isn't a lot of room for the lungs to develop. So they tend to have lung hypoplasia, and that contributes to their inability to win ventilatory support, so they tend to get stuck in the intensive care units for a while. But it's a good option in terms of repair, and the outcomes are pretty reasonable. You can see that overall in the long term, they get a repair and hangout survival is pretty good at the 8-year mark. You still have about over 90% of them surviving, and freedom from reintervention is also pretty good at the 8-year mark. So this particular procedure is safe, and it requires additional follow-up. In more severe forms of Ebstein's, they proceed down the single ventricle route. Now, tricuspid valve regurgitation, uncommon, but may be related to other valve anomalies, and they'll present with RV failure. So if the valve can't be repaired, then it has to be replaced. And again, there's criteria for that. But I just want to point those two out, that if a patient has incompetent tricuspid valves, an incompetent tricuspid valve, and they're undergoing a mitral valve procedure, because it's often found in association with other valvular disease, it is very reasonable to carry out the intervention on the tricuspid valve. That's what the guidelines tell us. And there's good evidence as well to support this practice. Although if it's the only problem and they're quite symptomatic, then it's reasonable to just go in and carry out the tricuspid valve repair as a primary procedure. In terms of how they do when you combine tricuspid valve repair with mitral valve repair, you can see that there isn't that much of a difference. The outcomes still tend to be pretty good. So if a patient is going in for another intervention, it's actually reasonable to advocate for the tricuspid valve to also get repaired. What are the other things that you must consider in these patients? Anticoagulation is the big thing, and I think the emphasis I'll place on that is that patients who have systemic valve replacements, they typically get mechanical valves, and they need lifelong anticoagulation. If they're undergoing some form of procedure, they must be bridged with heparin, low molecular weight heparin. So you tie enoxaparin or unfractionated heparin, which is easy to start, easy to stop, shorter half-life. When they have bioprosthetic valves, there is an initial anticoagulation requirement for the first 3 months, and after that they transition to aspirin, which is going to be in the long term. Main things, we'll talk about complications shortly, but that is one of the huge advantages of using the bioprosthetic valve, is that you have a diminished requirement for anticoagulation. In those who get mechanical valves, it is lifelong anticoagulation with there's always a risk of bleeding, especially as they grow older. In terms of things you should think about after valve replacement, complications, thrombosis is the big thing. And if you suspect thrombosis, you must get imaging, and if it's confirmed and they're symptomatic, then it's an indication for emergency surgery. If there is, a thrombus, but it's not that significant in terms of symptoms, then there's room for anticoagulation, fibrinolysis, and then watching and waiting. It can be evacuated in the cath lab, but again, this is high risk. Most of the patients will end up in emergency surgery. The other big risk to think about is infective endocarditis, so native valve endocarditis, so prosthetic valve endocarditis. And some of those groups, again, will need surgery. I'll share these slides with you so you can look at, but you can also access these guidelines. Some of these patients will need surgery if they get prosthetic valve endocarditis, and it's actually a class 1 indication. So if they're undergoing other procedures, they typically need endocarditis prophylaxis. Now, these are from the North American guidelines, but the European guidelines give you a bit more detail. So you can, in addition to the thrombosis you can get paravalvular leaks, you can get the valve failure itself in addition to endocarditis. So these are things that must be followed up in the longer term. So in terms of take-home messages, valvular disease etiologies are varied. They can be congenital, they can be acquired like rheumatic heart disease. There's good guidelines to suggest when to intervene, but these must be, you must consider your local setting, your context, the local context and the local capacity to undertake some of these interventions. Long-term outcomes can be good, but it depends obviously on the type of valve on which intervention is being done. And lifelong follow-up is mandatory for valve interventions, after valve interventions, or for the complications that come with them. I haven't touched a lot on the management in the CCCU, but thanks for those of you who gave feedback initially. That's something that I'll incorporate in the next time I give this talk. Thank you very much for your attention. I'll take a few questions, but it's 10:45. I'm not sure if there's any questions, but yeah, if there are, I'm happy to take them. If there aren't, thank you very much for your attention.
Looks like there aren't.
Yeah, doesn't seem like there aren't any questions. So I've either done a really good job or a very crappy job.
I know you've done an excellent job.
Right.
But
yeah.
also people can email you as well.
Perfect.
Yeah.
I forgot to include my email, but you can get it from Cecilia if there's any questions. And thank you again for attending the session. The Hong Kong and the Brazilians and I think the South Africans, it's probably nighttime there, but the Southern Hemisphere are enjoying their summer. So have a good one, everyone.
Yeah, and we do have a comment to say, thank you, great job.
All right, excellent. Thank you all. I've
Bye.
enjoyed it. Yeah, bye-bye.